So today I'm going to talk about newborn metabolic screening, which is a topic that I have been taught for more than 10 years. But then it's like I want to share about the basics first, and then we'll get into the details about the challenges from moving from a newborn metabolic screening to a genomic screening. Um, can you see, if you can see the slides, you can raise up or let us know at the chat box.
Yes, we can
So,
see the slides.
yeah, so I will also talk about some basics and history about the newborn screening, which is about the tender mass spectrometry. So first of all, we all understand that screening is a screening program, which is a method to screen a populations with unrecognized features about that disorder to find out that individuals. So there are different types of universal screening. So newborn screening is actually one type of universal screening. So there are other types of screening, including high-risk screening, such as the CA colon. But then the challenges in newborn screening is that we really want to achieve a high participation rate. So, and also, if we cannot achieve a high participation rate, sometimes it's very difficult for you to really screen out that patients with rare disease. So back in the criteria for screening, this criteria was a WHO criteria in the 1968, the Wilson and Younger criteria. And all these criteria are still hold nowadays. Some of the points are very important because for newborn screening, we want to put in those items in the screening program are recognized disease, which the treatment should be available. This is one of the very important point when you're considering to put in different items in the newborn screening program. And also there should be a period that patients may have asymptomatic or latent symptomatic stage so that you can identify the patient by this suitable test. And the test should be affordable and also acceptable to the populations. And also for those items that you have put in the newborn screening program should be clearly understood, including the natural history and also how it developed further to present. So with this, then the counselor and also the clinicians could explain to the parents before the testing. So it's like informed consent which will be involved. And there should be also agreed policy in that a locality so that all these patients, if they're being screened out, there should be a program that can enhance that those so that patients will have treatment. If those treatment is really very expensive, then the policy, local policy, if they support those patients being screened out for going for expensive treatment, then that condition could be considered to put into the newborn screening program. And there are more criteria that nowadays we also pay attention to is that some of the disorders had a recognized need in that locality. That means certain population may have a higher incident rate of certain genetics condition, and in that case, those items may not be put into other areas, but then it is a localized practice. And some of the condition we may not understand much, but then when you're running out the screening, it should be a program that involve education testing and also quality assurance. So basically, the condition should be important healthcare problem with early diagnosis that could benefit the baby, and also with a reliable and inexpensive method that we understand. So in Hong Kong nowadays, we have newborn metabolic screening, and also we have newborn the SMA screening. So in the past, back into 1984, there are only two conditions that started to have screening, which is a congenital hypothyroidism and the G6PD using cord blood. So since 2013, started from the CHK program, then the newborn metabolic screening was added, and later on with evaluation of different programs, then new items have been added to the newborn screening program from CHK and also to the government program. I would like to take this chance to just illustrate how counseling is important in screening, as simple as just as G6PD conditions. So G6PD is a condition which is an X-linked recessive condition. So you can say the incident rate for male is 4.5%, but for females, still there is 0.5%, because for the female carrier, if they have a condition called X-linked inactivation, these carrier may also become a patient if they had this X inactivation. So the genetic counseling involved here is that they need to explain, first of all, the natural cause of the conditions and also the clinical features and also part of the management and also precautions for these conditions. And the next is the inheritance pattern that the parents may need to know that the mother may be a carrier and therefore for the next pregnancy, if it's a male, 50% that will recurrence, and then for female, even though they are 50% being carriers, still with X inactivation, they can also be a patient. So that involve a lot, a little bit more genetics knowledge for a person to counsel the family so that they understand why there are males and also female patients. So in that case, if they could understand the consequence which may lead to the significant severe jaundice, then they will comply to the treatment. So this program have been running in Hong Kong for more than 20 years. That actually the precaution is to ask the patients to just to avoid some of the Chinese medicine and some of the Western medicines and some of the conditions that they may need to pay attention and tell the doctors and healthcare professionals when they are attending them. So I think this is a very good illustration for a successful screening program because, like in the general populations, when you mention about G6PD, it is not a surprise to them because they have already heard of the program, they understand their precautions, and therefore the acceptance is higher for the parents. But what if in metabolic conditions? Metabolic conditions could be new ideas to a parent and also some of the healthcare professionals because IEM is also a rare disease that may involve a single pathway which leading to accumulation of toxic substance and also in inadequate important substrates. So this pathway shows you that if there is an abnormal pathway from B to C, then the patient may present it with acute compensation, or the patient may present later on with different types of presentation, such as developmental insufficiency because of the end product, which is important for the brain development. So in that case, that may involve a genetics gene in that pathway. So IM disorders, there are more than 1,500 genes which may be involved. Most of them are single gene defects, although some of them may be maybe mitochondrial related, but then it all involved like with end result is the defective functions of particular enzyme. So you may understand that if we are just talking about genetic screening, which is screening for the gene, we can screen a lot of gene, but then if we would like to confirm about the disorder, we may need to have certain types of the functional enzyme study as a confirmatory testing in some of the scenario. So if we are going to plan for genetic screening for IEM, there are a lot of screen out follow-up planning that may involve. So therefore, it's still not yet running out. So this is a history for the evolved history of newborn screening back in those days with the graphic card spawning, screening for the PKU in US, and then in the 90s with the tandem mass spectrometry, which enhanced the screening panel. So therefore, there are more IEM panel, IEM items being added to the screening panel, and later on in different developed countries such as US, they have a unified recommended panel for screening. And back in 2013, CHK started the local expanded newborn screening program, and subsequently also hospital authority adopt the screening program. And now today in Hong Kong, actually all of the newborns could opt in to go for newborn metabolic screening, plus the new items, including the SMA screening. So the newborn screening involve a method using the dry blood spot collection at the heel break. While you got a large blood drop, then you dry it out horizontally. Then they can analyze for the different analytes. So sometimes the spot may be smaller, then that may result in some difficulties getting a punch for the blood drops. So this part of the procedures is also important for the program counselor and also coordinator to involved to teach the nurses or the phlebotomists who collect the blood and also for the laboratory about the precautions. Because all these collections will be really important to make sure a correct and also precise analysis for the different metabolites, including the amino acid panels and also the acyl-carnitine panels with different analytes shown here on 2 tables. So with that 2 tables in mind, actually we can identify more than 20 to 30 different types of disorders over these 3 columns: amino acid disorders, organic acid disorders, and fatty acid oxidation disorders. Different disorders may have different presentations. Some of them may have a more acute presentation with an earlier onset, and some of them may have a milder presentation with a later onset. And some of them could present it as early as the first 1 or 2 days. Therefore, the time for collection is also very important, and also a timely result for us to cancel and also identify those patients or at a latent period or those patients still at an asymptomatic period is very important. So you can see here in the amino acid group, PKU may have a high incidence, but then it may not present with acute decompensation. While the MSUD and also citrullinemia type 1 and also the argininosuccinate aciduria, though these conditions may present with very, very acute situation, while the patients may have a very high ammonia level, and therefore that may be presented with a clinical sepsis-like picture, or the patient may also get into a state like comatose status. And some of the organic acidemia could also present it quite urgently with acute decompensation, as well as the fatty acid oxidation defect as well. So while we select the newborn screening item, we need to know about how this patient will go through all this process listed here, because in that case, for each of the single items, you will know how to cancel the parents. So there are different types of newborn screening program running all over worldwide. So this is a very new journal that if you're interested to know about different newborn metabolic screening program using the dry passport, then you can take a look of this new paper by Professor Bradford Farrell, because this journal had included different areas, including Hong Kong, talk about the newborn dry passport testing. But then you may wonder, in different worldwide, they're using still biochemical testing reported in this journal. So how about the genomic screening? Genomic screening is actually in some of the program have already been run out as a trial in different localities. But there are a lot of challenges that we may need to overcome before we really think of a local genomics screening disorders. So with that 1,500, more than 1,500 IEM disorder in mind, do you think it is better to screen more IEM disorders at newborn? The answer is no, because not all IEM disorders should be included, because not all of them may have a very clear clinical presenting natural history, and also not all of them will have a easy confirmatory testing, and also not all of them will have an effective treatment. Even though you have screened out the patient. So this is the recommended uniform screening panel in US. You can see there are 29 conditions, and they have also had different add-on conditions after this unified panel. But in different developed country, because of the different consideration, such as the local healthcare system, affordability, the cost effectiveness, and also the incident rate in that localities, ethicals, and also insurance issues, you can see the range of the items being listed in the newborn screening panel varies a lot, such as in the US, there are more than 29, and then in UK, there's only 6 to 7 conditions being screened. And there are conditions that may consider to add on after you're running out a universal screening program. And there are, of course, items may be disapproved because those items have already gone through the criteria, especially the Wilson and Younger criteria, that if it does not fit, actually, those patients should be go for genetic testing or metabolic testing only if those patients presented. Say, for example, in this red circle that I have circled here, these are the items being disapproved. They have gone through a very detailed evaluation in the US program. For example, the Niemann-Pick disease, it is a severe IEM conditions. Those patients will have neurodegenerative presentations. Usually, maybe at a few years of age, the patient may gradually have deterioration, which may depend on different type of genetic variant, of course. But then if you have already identified those patients early, but then they don't have effective treatment, then actually it may not fit in the Wilson and younger criteria, and which should not be considered to put into the newborn screening program. So nowadays for driver spot that the suggested time is collected after 24 hours after birth to 7 days, because like for those early presenting conditions, if you do the screening very late, very at alert, after 7 days of age, actually those conditions may have been already presented. And this is the quality of the driver spot that I have mentioned to you, that you need to keep horizontal and keep dry, and also need to have a fully penetrance. The reason why I mentioned here again is that if those cards have an abnormal collection or unacceptable, usually it may cause false positive or false negative. So in that case, during our counseling, we may need to understand why some of the patient may have a false negative or false positive result. It may be related to the time of collection, and it may also be related to the quality of the driver spot. And for those patients who had a correct time for collection and also a correct appropriate blood collection, actually, there are also other possible outcomes from the newborn screening. Is that sometimes we may not the program may not running at a timely fashion. So it is important to offer a timely management, and also to make sure that after screening tests, there are confirmatory testing and also diagnostic tests could be followed. And also sometimes false positive may create some parental anxiety and unnecessary follow-up. And in that case, the counseling to this group of parents are really important. The sensitivities is not 100%. Some of the milder form of the IEM may not be able to screen out. So sometimes patient may present later on while they have acute decompensation or stress, or they may find out later on have a false negative result. So all these are really important if we can have a good counseling before the testing and after the testing, so that they could understand these kind of scenario could really happen. And the newborn metabolic screening nowadays worldwide is using blood, because the blood may have an international gold standard for the cutoff point, so that it is having a better reference. And also the false positive rate is lower compared using a urine, which will have uncertain positive results. So with false positive rate, high false positive rate, sometimes the baby may need to do more confirmatory testing, which is not necessary. And this may also increase some labeling effects, and also the insurance consequence and psychological impact to the family. So these are also the important information that may need to know before you counsel the patients. And for the results, most of them, 98% of the newborn will have the normal newborn metabolic results. Only less than 1% will have abnormal, while some of the patient will have uncertain results. Both of the uncertain and abnormal result patients may need to have follow-up, because it is important to make sure whether that uncertain group is having a high chance to be suffer from newborn screen IEM disorder or not. So getting to know the panel is important, because these panels tells you different types of the disorder, and also will tells you some of the analytes may have the turnaround time is really important. Some of the items may have urgent presentations, and some of them the presentation may be in slower. And then we also need to understand about the availability of the testing and also the treatment in that hospital calling back the patient, because some of the condition may need special milk formula or TPN, or certain types of medication which may help acute treatment to get rid of the high toxic analytes, and also some of the condition, if they really decompensate, may need NICU support, or also the renal team support for the hemodialysis, such as some of the acute presenting conditions which may have a very high ammonia results. So for each of the results, we need to plan about the follow-up and also the callback. So this is the American ACT sheet and also the algorithm that you may also take into reference for consideration if you are planning for your own screening program and also follow-up actions. Because with each of the conditions, the follow-up could be different, and the counseling is also very different because each of the individual IEM's conditions may have different presenting time and also different severities and also different clinical features. We also need to know about the parents' response during the counseling of the abnormal metabolic result, because some of the parents are really anxious about the results, such as in PKU, we may not want to call the parents a few days before we are going to see them because they may be worried about acute decompensations, which may not occur in PKU, but then they may worry about such condition because like these such as a newspaper may talk about acute decompensation. So we need to actually explain to them that which type of condition that we are suspecting and how those patients will be presented so that they may not misunderstand the condition that we are worried about. And for some of the parents, they may thought that the patient is right now asymptomatic, is doing well, the baby is fine. They may not want to come as soon as possible. So in that case, you may need to explain to the parent about the importance of early identification of those patients because the acute decompensations could be really dangerous, and some of the patient may get into renal failure or comatose status because of a high ammonia result. So this is one of the case that patient presented with elevated phenylalanine. So with suspected PKU in mind, so PKU with the PAH gene, which is defect the enzyme phenylalanine hydroxylase may not function well. So the cofactor PH4 may also help in this case. So while calling back the patient, actually we have to check about the availability of the BH4 loading test and also confirmatory testing. And we have to know that this condition is not that urgent that you may not need to call the patient that night. And then special meal formula should be available for the patients once after we do confirmatory testing, and then we can treat the patient as soon as possible. So we need to counsel the parent that this kind of conditions, you don't need to worry about acute decompensation. But then early identification, such as to identify patient with PKU before 10 days of life, then started the treatment, which is actually associated with a long-term better prognosis. So if it is over the weekend, then we may call the patient on Monday so that the parents do not need to worry over the weekends. So we would do biochemical testing using blood and also urine to confirm PKU, and also genetic testing to offer to the family. Most of the time that this kind of autosomal recessive condition, you may identify the parents as a carrier. And later on, actually for the next pregnancy, if those genetics findings are clear, showing pathogenic or likely pathogenic variant that we have already confirmed in their children, then actually a prenatal genetic diagnosis or pre-implantational genetic diagnosis could be offered to this family. This is the second case I would like to mention. So this patient presented with elevated C3 on the Friday evening. So because of the differential diagnosis include propionic acidemia and also methylmalonic acidemia, these two conditions may present it acutely with metabolic acidosis and also with high ammonia level. So in that case, we need to know this screening panel screen out something which is really a medical emergency. And also, patient may be presented with hyperammonia, even though apparently to the parent they look like asymptomatic. And NICU should be prepared, and also possible hemodialysis should be prepared. Medications such as the carnitine and anti-hyperammonia drugs should be available if we are handling this group of patients. And we have to know the parents' response and let them know that this group of conditions may require immediate medical attention so that they can bring in the patient back to hospital as soon as possible. So even though the result is available on a Friday evening, then the patient should be bringing into the hospital that night. Because high ammonia level could alter the conscious level. So in neonates or newborns, actually it's very difficult to identify early presentation of acute encephalopathy or acute order level of consciousness. Sometimes they may present like a sepsis-like picture, or some of them may have temperature instability, or some of them because of the brain control is not in that functions, or they may be already having metabolic acidosis, they may have respiratory distress. So this is the mechanism that they may want to compensate the metabolic acidosis. So in that case, early identification is very important, because if the patient is not identified, the patient may deteriorate further, may present with seizures or more severe acute encephalopathy, and or the patient may get into a comatose status. So high ammonia level is causing the astrocyte swelling and also dysfunctions. So in IEM disorder, there are a list of conditions that may lead to high ammonia level. So in that case, those items, if they're in the newborn screening panels, the nurses and also the doctors should pay attention whenever they call back this group of patients if they refuse to come. It is most likely because of the counseling is not clear cut, because usually if the newborn's parents understand it is really important and it may cause irreversible brain damage due to a late treatment, I think most of them will agree to bring back the patient to our hospital. So the duration and the severity of the high ammonia level is strongly correlated to the brain damage, and also the prognosis in some of the cases reported from the IEM's papers, that the durations and the peak level is correlated to the long-term prognosis of the intellectual and also physical impairment of this group of patients. And the third example is this term baby presented with 17 OHP more than 300. So we suspect congenital adrenal hyperplasia. So again, the counseling is that we need to let the parents understand the urgency of the acute decompensation, that the patient may deteriorate acutely with a salt losing episodes. But then before that, the patient apparently could be asymptomatic. So we do encounter patients that refuse to come, and then with repeated counseling, actually all of them will agree to come back to the hospital to get a double check. So I think these are the essential elements for you to prepare when you're counseling a newborn with a metabolic screening results. So first of all is to know the screening panel items. Secondly is to know about the available tests and also treatment for that particular IM disorder that you suspect with that results. And thirdly is to know about the parents' response. It implies that you need to tackle about different parents' response by a correct approach in counseling. Some of the parents may be over anxious, but some of the parents may be over calm that they do not want to bring in the child. So you may need to explain to them in details. So a successful newborn screening program is not just a test. It's really a program that rely heavily on a close collaboration between the nurses, the newborn screening laboratory, the metabolic physician, neonatologist, and also the chemical pathologist. So you can see there are a lot of different steps in the newborn metabolic screening that already very important to counseling. So our CHK newborn screening program is on the website, but we are not running the newborn genetic screening yet. The reason why is for genetics conditions. we understand that we may need a multidisciplinary approach. So the way from newborn metabolic screening to newborn genetic screening, that may need to have a lot of different planning and collaborations between not just those parties that I've mentioned just now, and also like we need to have the policy support and also the position statement from different expert, and also the most importantly is the general populations that they understand about those important genetics materials. So regarding newborn genomic screening, we understand in each of the single cell, there are 46 chromosomes. There are more than 20,000 genes. So nowadays, more than 4,000 genes already been identified, have a very clear correlations to monogenic disorders. So there are advocates asking about why not screen the newborn for the whole genomic screening so that we may understand the one with a genetic disorder earlier on. And actually, this may involve a lot of different concerns. For genomic screening, because the testing is too powerful in one single sequencing, you can sequence a lot of genes. So it really depends on the panels that you pick into that screening panels. It is possible to screen out some of the conditions that may have a late adult onsets. It is also possible to screen out some of the untreatable disorder, and it is also possible to screen out the mild phenotype disorders. And of course, the most problematic issue is that you may identify some molecular variant with uncertain significance, where both the doctors and the parents may have anxiety or uncertainty in handling this kind of genomics data. And with a huge of newborn genomics data, it could also cause a possible ethical issues or possible legal issues, and some of the public health concerns such as the data security, the privacy, the potential discriminations, and also possible insurance issues. So genomic screening can help, but then genomic screening can also have some power which, like the old traditional biochemical screening program may not overcome, such as like the genomic screening can identify conditions which the biochemical screening cannot. Say, for example, that abnormal analytes could not have an easy method that you can detect it from the blood, or the tandem mass spectrometry or some of the different types of blood tests could not identify the abnormal analytes. That could be in the different types of tissues, or that could be in the brain, or there may be no biochemical analytes which is correlate, but then that is intracellular conditions which may lead into subsequently presentation of intellectual disability. So in that case, there are still drawbacks. And genetic screening may also allow early access for some of the conditions if it is quite clear that definitely those genomic variant is causing disease, that those patients being identified so early on, they may have a higher possibility to go into different clinical trials, because there are different clinical trials for different rare genetic conditions. Sometimes the inclusion criteria may set in while the patient presented at the stage or being diagnosed later on at a stage which may not fit the inclusion criteria, then those patients may lose a chance to join in the clinical trials. So early diagnosis may help this group of patients to get early access to different types of clinical trials. And there are different position statements from leading bodies telling us that actually, with the potentials of the powerful genomic screening, actually we can screen out patients earlier on. But then there are a lot of precautions, and also there are a lot of issues that we may need to address before a region really roll out universal genomic newborn screening. And there are also different papers or groups that get the parents' attitudes to the genomic screening, whether the parent accepts. So most of the research study also show that actually the general population had a high acceptance towards the genomic screening than some of the expert in the area in this area. The reason why is that in the populations, parents usually tends to wants to help for the rare disease patient to get early treatment. Sometimes they may not understand if this kind of genetic testing is rolling out as a genomic screening program for those asymptomatic patients. What are the possible consequences and what are the possible challenges that the society may need to face or the healthcare system may need to face? So, but then it's also a good point that the general population are really open-minded to a more neuro types of approach for newborn screening. And in that case, with the high acceptance from the parents' attitudes, then I think it is really important for the locality, for different stakeholders to discuss and also to plan for a possible genomic newborn screening program. So factors that may identify for consideration to design a genomics newborn screening program may involve a different areas. So I have mentioned in just now about the parents' uptakes, acceptance, but actually we also need to have the healthcare providers, which they can be able to offer the pre-test counseling, because in that case, we're talking about collecting genomics data and also for analysis and storage and possible future use. So that consent will not be a very simple and straightforward consent. We need to make sure that also the parents may understand about the possible consequences, and also for the design of the different genetics conditions into the panel, the gene selections and also analysis is really important, because as you understand from the first part of presentation, newborn screening program is a time sensitive program. Time is a very important element. A timely diagnosis will lead to a successful program, because otherwise the patient may have been already presented. So there is no difference between doing confirmatory testing without a genetic screening. So in that case, it all lead to the consideration is about the validity and utilities of different testing for that conditions, and also the method whether in that locality you have enough manpower and also laboratory support, and also the analysis whether it is accurate or not. It may also lead to a consideration for ethical and legal implications that some of the ethics group may support, and some of them may not support the early diagnosis. So there are different types of newborn genomic screening studies launching internationally. So you can see from this diagram, it shows different cohorts with different size and also different panels. Some of them have more conditions, some of them have a smaller conditions. So if you're interested, you can also get into the paper that I've just now mentioned to you, because in all these different type of program, actually there are a lot of different message that you may also consider when you planning or think about whether genomic screening should be in that localities. You can see that with genomic screening, it is very powerful that you can give precision treatment. Some of the conditions may be treated using cell therapy. Some of the treatment may use all oligonucleotides. Some of the patients may go for gene therapy. And all these treatments are we talking about here are very, very expensive treatments. So without a local policy, if you have screened a patient but without treatment, actually those patients is also suffering from an early diagnosis because they can't afford the treatment, but then they're being diagnosed, and that may cause a lot of psychosocial stress as well. And you can also see that for accurate diagnosis, rapid testing, and also later on multi-omics confirmations, it should be important elements that you consider whether it is available in the hospital or in that locality for further confirmation of different genomics conditions. So this is the conditions that I've encountered in the last month. It's actually a good conditions that is for us to illustrate how genomic screening may potentially encounter some difficulties we are going to roll out. So this patient presented with multiple brain cysts. So with the antenatal presentations, genetics testing was offered, and the patient have the genetics result before delivery. So we have to explain to the parents about the genetics findings on the day before they deliver the patient by elective cesarean section. So this gene find out that this patient presented, the twin presented with brain cyst is suffering from GA type 1, which is one of the IEM conditions. It's very clear cut that the genomics finding is a pathogenic finding, and the patient is delivered that we can give the patient special treatment with the special formula, and the patient is stabilized. And then the newborn metabolic screening result come back. And the newborn metabolic screening result come back showing that it confirmed the same findings. So for the genetics findings, we have done on one of the patients. So we have to do the genetics confirmation for the other twin. So treatment have been implicated. So you can see that this is not a genetic screening in this case. This patient presented with brain cysts, but then it really takes quite a long period of time for us to cancel the patients before the patient deliver, and also subsequently we need to cancel the family about this, the other twin, because it's a mono MCDA twin, so that the other twin could probably having the same conditions that we need to treat the patient despite all these other investigation confirmatory testing is not available yet. So in that case, it involves a lot of counseling and also a lot of education to the parent, because basically the patient is not delivered yet. So we can use this case to illustrate actually with this kind of genetic diagnosis earlier on, which may lead to a lot of post-test counseling. Manpower is actually a issue because for this patient, we have to explain about like the gene functions and the treatment. It is good that GA1 is quite clear cut. We understand about the pathway and we understand about the treatment, and then we can give a very clear um, planning for confirmatory testing and possible prognosis and also the treatment. But then genetics finding is too powerful that also identify a variant on one of the gene, which may lead to autism and also intellectual disability in future. So with this variant of unknown significance, we may not know whether the brain cyst is related or not. We may not know about the long-term prognosis. So in that case, only time can tell for the different for the patient's long-term prognosis, because in these conditions we cannot give a good functional testing. So there are different types of newborn genomic screening program, like proposing for screening for neurodevelopmental disorders. But then getting into different literatures, we understand that actually are we really there yet to implement on newborn universal genomic screening for even the neurodevelopmental disorder? I think with different type of literatures, the most important information and also message to us is that you need to identify those conditions which really clear about the natural cause of the history and also possible treatment. So the challenges that we need to overcome from this stage to the genomic screening is that we need to plan for facilitating informed consent at scale, because it's talking about a universal screening program, and also the possible manpower issues, because the sequencing is involving a very large number of general populations, the newborns, and we need to have a low cost and high speed sequencing facilities, because newborn screening program, the time is really a issue. If the sequencing result come back like a few months time, then it may not be that considerable. So there may be also issues with the data interpretation. Sometimes we may identify pathogenic variants, but those variants may have a variable penetrance within the family or interfamily. So in that case, it's also a challenge to counsel the parents or the family about the future prognosis in those cases. And I've mentioned about the workforce and also the resources implications and also the availability of confirmatory testing. So there are more than a few thousand types of genetic disorders. I'm quite sure some of them may not have confirmatory testing. So in that case, it may lead to a very difficult situation that while you have identified a asymptomatic person with a possible molecular conditions, but then the patient do not have symptom yet. So are these patients going to have these patients are going to have face some of the difficulties like psychosocial stress to themselves, to the family, and also whether that may cause insurance issues in futures, and they may also concerned about the impact of the uncertain results, such as the case that I've mentioned about the VUS. It is not just about like getting a VUS, you may explain to family about the uncertainties. Sometimes with different presentation, different clinical features presentation, you may not understand whether that is really related to the uncertain variant. That may cause issues in getting a good counseling in terms of a long-term prognosis. But then there are also potential benefits that we understand that the newborn genomic screening could have, is that new items, new conditions could be added quickly if the sequencing data is already there, and also that the sequence data should not affected by the maturity of the patients, or whether the patient is put on new by mouth, or whether the patient is sick or not, because for biochemical testing it do affected by the maturity, and also whether the patient had full feeding or whether the patient is ill or not. And also the patient may have potential benefit like a greater access to precision medicines for rare conditions. And also those stored genomic data can be reused and reaccessed for other informed clinical use and for future use, like offering for more screening, such as while the patient achieve adulthood, that they may want to consider a reproductive carrier screening or pharmacogenetic screening, or later on with adult onset screening. So those they can reuse the data that have been already been sequenced and in the database if it could be identified. So if it just could be identified, that may means that you may need to have a very secure database to store the genomic status. So privacy and also data security could be issues. But of course, a newborn genomic screening involve universal screening of newborns. They may have different types of healthcare outcomes. So it could be a very rich resources for future healthcare data for research and also to improve the diagnosis and treatments. So all this newborn screening or possible future genomic newborn screening could really depends on the multidiscipline team approach and also management. So timely management with a good collaborations will lead to a successful newborn screening program. So I think it is not a single unit or a single test that could compare to a really coordinate program. So I think that's it for my presentation here. So I acknowledge our group and also our nurses, genetic counselors, and Dr. Yao here, that we're running the newborn metabolic screening at the Prince of Wales Hospital and also Chinese University here. And then I would like to thank you for your attentions. So I will welcome if you have any question regarding for newborn metabolic screening or newborn genetic screening.